to everyone for joining today. My name is Sadia Zapp, and I'm on the communications team here at the Breast Cancer Research Foundation, where I've served for the last 9 years, astonishingly. In 2022, about 7 years into working at BCRF, I was diagnosed with breast cancer at the age of 36, just after moving to a new town, into our first home, and with my then 4-year-old son starting a new school. And even despite all of my years at BCRF, I still couldn't believe it. So while my story is still relatively rare, it's not actually that unique. I mean, just in the past month, we've had these two famously famous announcements by Olivia Munn and Kate Middleton announcing their cancer diagnosis and treatment, who are also young moms. So yes, while breast cancer incidence in women under 50 is still relatively rare, accounting for only about, I believe, 12% of new breast cancer diagnoses each year, it's on the rise. You know, there's been an 8% increase of breast cancer among younger women ages 30 to 39 over a 10-year period. And this is really alarming because up to 55% are diagnosed within 5 to 10 years of giving birth. And that risk is particularly highest for women who have their first child after 30. Hello. Younger women under 40, right, are particularly vulnerable because they're not receiving annual mammograms, nor should they be. But if they aren't identified as high risk due to a strong family history or genetic predisposition, they're likely not being screened. So the other thing to know, and one of the reasons this is so alarming, is because younger women have a higher incidence of triple negative breast cancer. And younger Black women specifically have the highest incidence of TNBC compared to other groups. So, of course, I'd mentioned Kate Middleton, who has an undisclosed type of cancer, but it's important to note that the increase of incidence is not exclusive to breast cancer. Colorectal cancer has seen the largest increase of incidence in people under 50. So now I'm joined by two experts to explore the challenges young patients face, specifically moms, when diagnosed with cancer, the increasing incidence among women under 50, and of course, what BCRF is doing to address this trend. And with us today is Dr. Ann Partridge. Dr. Partridge has been a BCRF investigator since 2016 and is the grant recipient of the Pink Agenda Award. Dr. Partridge wears many professional hats, but is a renowned expert on breast cancer in young women. Notably, she is the co-founder and director of the Young and Strong program for young adults with breast cancer at Dana-Farber Cancer Institute in Massachusetts, where she also directs the Adult Survivorship Program and serves as vice chair of the Department of Medical Oncology. We're also joined by my friend, Marcella Kelson, who is a maternal wellness and parenting expert and mom of 2, who was diagnosed with triple negative breast cancer at the age of 35, just weeks after her daughter was born. Welcome, Marcella and Dr. Partridge. Before we dive into this topic, I do want to just quickly acknowledge how emotional and difficult this issue is. Infertility and motherhood is a weighty subject for so many women, especially facing it alongside a life-threatening illness. So first, I'm going to turn to you, Dr. Partridge. On this panel, you have 2 moms diagnosed with breast cancer under 40. How common is breast cancer and cancer in general in women under 50?
Well, thank you, Sadia, and it's great to be here with Marcella to talk about this important issue. It is not common, so we don't want to be alarmist. Most young women won't get breast cancer, but too many young women will. And as you alluded to at the beginning, when a person is diagnosed with breast cancer, there is about a 12% chance that she'll be under 50 at diagnosis, which means the vast majority of people diagnosed with breast cancer are over 50. And so whenever we want to learn about our youngest patients so that we can help them more, we have to do dedicated efforts to understand the youngest, because when we pool all the breast cancer people with breast cancer together, patients with breast cancer, they swamp the young ones if you put everybody together. And so that's why we and others focus on our youngest population. So it's not common, but it can and does occur. A lump can be breast cancer or a change in the breast. So we always talk about, like, public health announcements 101. It can happen. and make sure that you talk to your doctors if things aren't going away or something's concerning you.
Mhm. And so we talked a little bit about how, yes, it's still relatively rare, but it's growing, right? And incidence is clearly on the rise. What do you think are driving these alarming trends?
Yeah, so there's a complex relationship between both genetics, environment, and then as we started this conversation, the experience of a pregnancy or not, and development of breast cancer. So we know that the older a woman becomes, the higher likelihood of getting breast cancer. That's, what I was just saying. Then if there's a pregnancy, weirdly, women are actually protected in their long term if they have a pregnancy before age 30.
Mhm.
But pregnancies after 30 or no pregnancies, those women are at higher risk in the short term if they have a pregnancy after 30, and in the longer term if they have no pregnancies. So it's a very complex relationship, and a lot of our scientists are actually digging into the what's going on in the breast of a woman who has a pregnancy and then goes on to get breast cancer. Is there something in the postpartum breast as it changes and involutes, we call it, after lactation or not, that drives an abnormal cell to become a cancer, or a cell to become abnormal to become a cancer? So complicated, lots of science going on there. And we're very hopeful that someday we'll understand all of that better. But we think that's one of the drivers.
Mhm. And I think I want to just point out what you were talking about as well here, postpartum cancer, because it's not just what we think of postpartum as the first year or few years after a birth, but that risk is between 5 to 10 years after you have your first child, if it's the first child after the age of 30. So I also know, I want to be clear, we don't want to say that older moms are to blame, or there's no victim blaming going on here, because obviously you've got two moms who had children in their 30s as well, but it's
Three moms that had children in their
right,
30s,
right,
well
there you
into their
go.
30s.
Yeah. But it's also to just clarify that if you feel something suspicious, don't just brush it off, right? So it's part of that PSA you were saying, where it's that need to be aware of your own body, especially if you've had a child after 30. So, of course, Marcella, you and I were both one of those women. And as rare as it is, we somehow found ourselves leading eerily parallel lives just a few towns apart. Tell us about how you found your breast cancer and what your treatment plan entailed.
So I was talking to my husband about this yesterday. I'm fairly certain. So we were doing my daughter was 3 months old. My son was 3 years old. And my husband and I were going away on our first kind of post baby 2 days off, little trip up to Connecticut, up to upstate Connecticut. And I'm fairly certain I saw a drive pink license plate. I was trying to figure out exactly how it happened, and I was in the passenger seat, and I said, you know what? It's been a while. I had a breast check at 6 weeks because I requested it, but I said, it's been a while since I've felt around, and so that was only about a month before. Everything had been fine, but I actually have always been pretty good at just feeling things around, like feeling around and making sure that everything at least felt my normal, right? And when I placed my hand on my left breast, it felt like almost like it harder. It didn't feel, there was no lump. It just felt like the tissue was different. And so I compared to the right, I compared to the left, I compared to the side, and I said, something is not right. And I am very fortunate that I work with a lot of really incredible doctors, nurses, etc. And my OBGYN is actually a friend of mine. And I texted her, I said, something is not right. I found something. I need to get it checked out. She said, go immediately to get, as soon as you can, go get imaging, and just like, don't be paranoid, but just check it out. And I assumed that it was hormonal, but on some level, I also had that feeling like, okay, this is something I'm concerned about. And luckily I was taken very seriously, which we know a lot of minorities are not. And so I felt very lucky to be able to schedule a mammogram a few days later. And on the spot, they told me, we just we don't like what this looks like. You need to come back tomorrow morning for a biopsy. And things, 4 days later, on a Monday, I was a normal mom with a 3-month-old, 4-month-old, and 3-year-old, dropping them off at school. And then on Thursday, I was diagnosed with, triple negative breast cancer, and I had no idea what this was. I was on a Google black hole just with the scariest outdated statistics. And that is when I started to really try to educate myself around the science and the biology and why was this happening, and try to, get through it. So I was treated at MSK we have the same, strange enough, actually, BCRF scientist, Dr. Elizabeth Coleman, which is how I learned about BCRF. So feels very full circle to be here with you today.
Well, thank you. And same, I'm so grateful that you were able to join us today, because that's a harrowing story, but kind of underscores what I was saying earlier, which is that especially when you're a young mom, it's easy to forget about yourself and be so focused on trying to sleep through the night, or just barely waking up and being there for your kids and your husband and your family and whoever else is that you're helping to take care of. And for a lot of people, that can include parents and all kinds of things. But I think you spoke to that intuition and that speaking up for yourself, and luckily finding people who listened to you. So you already had those people in your life that were willing to listen to you, which I think is phenomenal, because we'll touch on it a little bit later. But I do think it's unique to have people that are not dismissive specifically of young patients. But
especially postpartum, when there's so many breast changes that, waited out. And so, yeah. And it's not a coincidence that I found this on the first day that I was without my kids, just that is such a reflection of how busy we are. And if you have the privilege to slow down, and that is a privilege to be able to slow down. So I did not take that for granted, to have that moment to even check my body.
Yeah. And of course, having that intuition to do that check and be aware of your changes to your body. So Dr. Partridge, can you share a little bit about what triple negative is?
Sure. And I just wanted to congratulate Marcella on bringing it to attention. So it's not just noticing it, it's, because there's a lot going on to actually both have the courage and the time and the attention yourself to say, hey, something's not right, because there's a lot of all that goes on that can cause delays in young women in particular getting diagnosed. So you asked me what triple negative breast cancer was, is that? So triple negative is an unfortunate term for one of the subtypes of breast cancer. There are 3 major subtypes. One is ER positive, HER2 negative. These are named after the receptors that are expressed on tumors or not. So if it's ER positive, HER2 negative, we call it ER positive. If it's HER2 positive, regardless of whether it's ER positive or ER negative, and PR is there too, that's one of the other receptors, we call that HER2 positive. And then sometimes if it's ER positive or PR positive, we'll also use endocrine therapies. And then triple negative is that the cells on the tumor neither express ER, PR, or HER2. So they're named for the absence of having these 3 different receptors. And it's important because it drives how we treat cancers from those big buckets, recognizing there's nuance within them. And of course, triple negative is a bit of a wastebasket, so to speak, of different types of breast cancer, all of which don't express these receptors. So that's why it's named that. And again, scientists and clinicians like myself and clinical researchers, we're trying to figure out, both what is unique about these cancers and what we can harness to better treat and therefore improve the outcomes of all of our patients who get diagnosed. And we're getting there, as we'll hear about, I think, when we talk about treatment in a little bit. But that's the gist of it.
Right. And I want to talk a little bit about how different it is and the evolution of how we've talked about TNBC. When I first started at BCRF 9 years ago, we would say there are no targeted therapies for TNBC. It has been so gratifying to be part of leading that changing the way we're talking about TNBC, because now we don't say that anymore. We can't say that anymore because there are targeted therapies. We have PARP inhibitors for those with BRCA mutations. Marcella, we were talking a little bit earlier about immunotherapy like Keytruda for early stage triple negative disease, and even an antibody drug conjugates that I think are very exciting in the world of treatment for late stage TNBC right now, and all of these things, I just want to say, I was looking at a study earlier about mortality trends in the US, and one highlight is that we are moving the needle. There is a smaller rate of mortality among TNBC patients. I mean, that is moving the needle. That's what these treatments are doing, is saving lives for, primarily this group of women who are disproportionately younger when diagnosed with TNBC. So, of course, this is a tough disease, regardless. Marcella, what was it like to navigate your diagnosis while caring for a newborn and a toddler?
So the first thing that I did was I enabled all the support that I could. I'm a doer. I think all of those, evolutionary drives of just trying to figure out how we were going to get through really kicked in. I had my parents actually live abroad, and I was very lucky that they dropped everything and came over to help me, because for those of us who don't know, Keynote 522 is the protocol that addresses early stage triple negative. And it consists of 16 rounds of chemotherapy, different types of chemotherapy, 19 rounds of immunotherapy, radiation, et cetera, et cetera. It's a very exhaustive protocol, and for good reason. But what initially I realized is that there's no chance I'm going to get through this alone. So these are all forms of privilege, right? I was very lucky to have my parents support us. I was very lucky to have school, right? The first thing I did is, much like you, Sadia, my son was starting at a new school. So first thing I did is set up a meeting with the head of the lower school. We also had childcare. We had a nanny that spent most of my time with me, and even had hours of help on the weekends so that everything wasn't on my husband. But my treatment was every week. So by the time I felt better, I was back in chemo, and it felt like there was very little ability, honestly, to connect with my children in the way that I wished to connect with them. And I just want to be honest about that, because there's so much grief and loss in the time that we, lost together. But what I tried to do is really be there for the moments that I knew I needed for my mental health. So no matter how much I needed to sleep that day, I wanted to be there for dinner. I wanted to be there, to drop off my son at school. So I tried to function in the ways that I could in the times that I knew meant the most to me.
It's so tough, right? So when you're talking about being there for yourself as well as for your kids, that support system, I think, is critical, and whoever comprises that support system is unique to you, right? And so you built your team based on the people you had available to you. And I think that that's true for any patient. You really have to do that, reach out and be specific. I think we experience also a lot of people. I think one of the silver linings and beautiful things, if you can say beautiful things about being diagnosed with cancer, is that all of a sudden you realize how many people love you. Like, I had no idea how many people cared about me. I was like, what? I don't even think you knew my name. So I'm shocked. And so many people reached out, and it was really a beautiful thing. But a learning for me also was asking for specific help.
Yes.
So I think it's so, and especially as young women, young moms, and people who have careers and are working and doing all of the things, it's really hard to ask for help. right? It's like so hard, so unnatural
Well, I
to,
think we always feel like a burden. It's
yes,
just,
yeah.
right?
And we're so used to unburdening others. So being the burden is like, how, that doesn't happen. That's not going to work. So we find ourselves, you know, being unable to be very specific, especially as people who are reaching out. Let me know how you can help. So if you are a caregiver and you're a loved one, I would say that's the biggest challenge, is that people will naturally fight that instinct to ask for help. So when you're asking a patient, how can I help? That's giving the patient kind of homework to do, and you're putting the onus and burden on the patient to figure out how you can help them. So I always say, like, just do it. Just, you know, if you feel like, depending on your relationship with the person, to show up or offer childcare and offer just specific ways to help. Like, hey, can I come over and do your laundry? Hey, can I take your, you know, kid to the park for an hour? So that's just my aside to people who are watching on how you can help moms or other loved ones in your life battling any kind of illness, frankly. But
Can I add something on that? One of the things I tell patients, and I think this is good for anybody tuning in today, is if you're a patient or a loved one or caregiver of someone who's going through this, especially early on when it's all so new, sit with that person, or for yourself, make a list of the things you actually wouldn't mind outsourcing, that you would actually take the help for. Make that list and then give it to your caregiver and say, if someone says, how can I help, in that nebulous kind of trying to be helpful, but actually making you do work, oh, I've done the work and I have, if you could do X, Y, and Z, that would be fabulous. And especially if you can have your partner or your mother or whoever else is kind of helping you manage, say to them, well, you could help with this and that, then you can actually put them to work. They will do great things for you if they mean it. And you don't have to do the work in the moment, right? Like, what could you do? Because I will say that I found that, and maybe Marcella and Sadia, you could comment on this. I've found that my patients, when someone says, oh, I'll take the kids for you, sometimes that is helpful. And sometimes they're like, no, 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 I need my kids with me. You can go get the groceries, but they don't want to ask. So people only offer certain things, not necessarily the stuff they really want the help with.
Mhm. Right, exactly. My favorite is always laundry. It's like, please, I'm not going to ask you to come over to do my laundry, but I would so love it if you came over and did my laundry, at least for my kids. But yes, exactly. It's those things, the invisible work that maybe we're not all as aware of. But, you know, we were talking about what it was like having a toddler and a newborn, but I'd love to hear also specifically your toddler who was able to talk and you could sort of explain things to him. And even as he's grown, even in your sort of survivorship state, as he's growing and seeing the changes, how do you talk to your little one?
So it's interesting. I think that I've initially visualized it as like a big conversation that I had to prepare for. But once we began talking, I realized it really needed to be small conversations over a period of time that allowed him to just process one step at a time, right? So the first conversation was about, he's very science and math leaning. He's very left brain leaning. So I really met him in his interests, right? His authentic interests. And I said, I had an encyclopedia, a children's encyclopedia, and I said, I have to tell you something. My body made a mistake. My body made a mistake. And sometimes our bodies make mistakes when they're really busy doing other things, taking care of other parts of our bodies. But what happens is there's something that grows, and it's a group of cells, and that is called cancer. Or that is called a tumor, I said. And then I kind of stopped and he said, oh, what is a tumor? And I said, tumor is a group of cells that are unhealthy, right? And the way that we have to look at that tumor is we have to think about what can we give that tumor so that it becomes healthy again, or so that the unhealthy cells go away. And I really kind of like slow down and let him look at the pictures in the encyclopedia and just say, is that so? And then after that, I said, I have to start to take a medicine because right here on my left breast, I have a group of unhealthy cells that need to be treated, right? With medicine. It's not medicine that you take. It's not medicine like like you take when you have a headache or, you know, whatever. It's a very special kind of medicine that is made by superhero doctors, I said. And I really brought in this superhero idea because I even showed him pictures of Dr. Coleman. I showed him pictures of Dr. Here over time, right? That wasn't the first conversation, but I wanted him to see that I was in the hands of superheroes. And to him, that is something that he could really grasp as, okay, when she's going away for the day to the hospital to take this medicine, she's with superhero doctors who are using these super machines, right? So I actually found a picture of a Lego MRI machine. I couldn't get the actual Lego, but I showed him, I said, this is what it looks like. You know, we use these machines to make sure that the medicine is working. And by the way, like after these conversations, I would sit and bawl. I know that I've had a little bit of space, so I can say it really like matter of factly. It was a very emotional conversation, but for the sake of this conversation, I'm trying not to bawl. But he, you know, he could really grasp this idea of, I'm taking a medicine, it's going to change the way I feel for a little bit. I'm going to feel tired. My hair is going to change. It might fall out. It might get shorter. I won't have the energy to do the things that you're used to me doing, but over time, I'm going to get better and better. And then I said, by your birthday, I'm going to be finished taking this medicine. So I used a time marker to give him a sense, right? He's 3. He still doesn't really know what his birthday is, but at least he knows it's within a realm that he can understand. And what's really interesting is he really fixated on, in that conversation, on how I was going to get there. And, you know, he said, well, how are you going to get to the doctors? And I said, I'm going to drive. And he said, you're the best driver, which first of all, is not true, but he thinks I'm the best driver. And I think that that is just such a reflection of how small, like how small you can really take things when you're really just talking about how am I going to get there? And how much, you know, we see cancer and we're terrified, right? Of course we are. We know what we know how what it entails, but they see whatever we present to them. And so what I really try to lead with is confidence in the doctors, which I genuinely had. And I try to lead with a sense of containment, like this is going to end at some point and we're going to get through it. And so it kept being, and it still is till this day, a series of conversations. And I'll just end with saying that I was recently at an art class with him, and I lifted him up to show him something, and the owner said, wow, your mommy's so strong. And he said, my mommy wasn't always strong. She was really sick, but never heard him express this. She was really sick for a long time, but actually she took this medicine and the superhero doctors made her better. And now she's stronger than ever. I swear I've never said any of these things, but you could see that over time he was collecting the information that he could process. And so it's us not actually rushing them to understand with our own anxiety.
I think that first of all, arrow to the heart. How sweet is that story? You know, that is the sweetest. Sorry, I'm like,
I know.
Stop me crying over here. That is so sweet. I think I had a very similar experience with he was 4 at the time, and we were starting pre-K. It was challenging for us because we had just moved, and it was only a month after we'd moved. So now he associated which was hard enough. I don't know if you've seen the new Bluey episode, but moving is a very big challenge for little kids. But on top of that, he now associated our new town and home with mommy being sick. I took the same path as you, though. I did try to be as honest and explicit as possible because they're little sponges and they pick everything up. And little conversations that I might have thinking that he's not paying attention with my husband, he absolutely was paying attention and would ask me about them later. And it's exactly what you said. It's that being kind of explicit at their level and meeting them where they are. So we did the same superheroes. For us, the superheroes, the villains were inside of my body, and the superheroes needed to get, one of his favorite things, supercharged by using my hair. So that's why mommy was going to lose her hair, because the superheroes inside of my body, the medicine needed to get supercharged, and they needed my hair because my hair is just so powerful. Like that's how much power is in my hair. So that work, like once I started talking about it in terms of superhero evil versus good and inside of my body, and once I'm done, this isn't contagious, it's just inside of my body,
Yes.
and then it's over. That really worked for him. Now the interesting thing for him was I'm letting my hair grow out, as we are all seeing this in live form. It's happening now. It's in a very awkward place.
You and me both. You
Yeah,
and me
I know.
both.
Like going through the.
You never know what you're gonna wake
Beautiful.
up with,
You
but it's
never
all
know what
good.
you're gonna have when
Looks
you
good
wake
today.
up.
Looks
Yeah,
great today.
thank you. No, but I actually really liked having short hair, but for him, I'm only growing it for him because he had really short hair. Like he thought I would be done with treatment and wake up with long hair. He didn't know it would take time to grow back, which I didn't realize until he said, when is your hair coming back? The whole time that I had no hair didn't affect him at all. But once I told him I was done with treatment, he just thought I would wake up the next morning with long hair again. So I just think that that's fascinating, is there are levels to his experience that I'm not even aware of, even as often and as deeply as we communicate. So I love that. And one thing I did want to talk to you, one last thing about, not last thing, but one thing I wanted to talk about is, in the middle of all this, you somehow managed to raise over $30,000 to support BCRF and start an online community. You launched a Substack series. You got groups of women together that I loved, and I've now become friendly with some women. Motherhood Through Cancer, your Substack. I join or go and read and subscribe if you don't already. And I've met a couple of friends. What inspired you to do these things on top of everything else that you were going through?
Well, because I was so fortunate to have so much support at home, I actually what I really wanted was for people to become more aware of what was going on, because I just want people to be really empowered around their health. That's why I do what I do. So my birthday was coming up. It also happened to be my last chemo session. And I shared a lot of my journey on Instagram. So I got a lot of people who are emotionally invested in my journey. And I had a feeling that around my birthday, there was going to be a feeling of wanting to be involved. I mean, that was what people would, say to me, especially my friends. And the last thing I wanted, because I remember I would get flowers. And by the way, I love flowers. So, there's no dig on flowers, but I remember I kept thinking, imagine if I could take the value of every bouquet and just put it towards research. And I couldn't stop that visual immediately in the beginning. I couldn't stop thinking about it. And so I actually reached out to your team at BCRF and I said, I think I want to, how do I do this? I want people to feel like they can help me, but I wanted to do it in this way that is specifically meaningful to me, because as we know, research is the reason why 6 months prior, Keynote 522 was approved. And that is possibly what saved my life, right? So I feel so connected to the research because of how recent, because of how imminent these changes are, right? And so I said, I'm going to throw together an Instagram fundraiser. I shared it on my story, and I woke up the next morning and I had raised $10,000. And I said, how did the people just wanted to share? And they continue. And it was the way that I asked my community, back to your point, Anne, or Dr. Partridge, is Anne. Okay. I know we spoke before. So back to your point, is like, that is how I asked the community to be involved. I really appreciated the concrete help, but to me, my love language is research. It just is. And so, and it is the gift that keeps on giving, because we know when we make a breakthrough in the US, the UK then is in, every other country is impacted. Every other human is impacted. And so people continued to share. From one post, I was able to raise over $30,000. And that was just on Instagram. For international people, they went through the website, the BCRF website, and raised more. And so it just felt like people could, and I said, donate your lucky number, donate your whatever. It needed to feel emotional to me. I said 36 or your lucky number. And so people got, I saw all sorts of different values. I learned all people's, I learned about people's lucky numbers, and it kind of felt like this outpouring of positive energy that kept on giving.
I think that, I mean, I don't even know. There would be a chorus of clapping hands right here if you could see. I know
It felt
my
so good.
team's definitely feeling the same way. So thank you so much for that. And
Oh, I didn't, thank the people who donated. That's how I'm
my
eternally
love
grateful.
language, my love language is research. Can we frame that? I think for all of us.
It's true. I mean, that's how and I'm sure you're the same way. I think research makes me feel safe, and research makes me feel hopeful. And that is why BCRF is so valuable to me, because that's where I grounded a lot of my anxiety. And that was one of my coping mechanisms, is what are people like Anne and, the other doctor, what are you guys working on that can make us feel hopeful about the future? And so I'm going to stop talking now, but that is why it's my love language. Yeah.
And sort of pivoting and carrying off of what you were just saying right now about being hopeful for the future. And we know that young patients in particular face unique challenges when diagnosed. One glaring challenge, of course, is the issue of fertility. And in fact, I just read a New York Times report the other day that was talking about how infertility was the greatest fear, second only to recurrence, that young patients carry. Those are the two fears. Those are the two things I carry with me every single day as well. What options are available to newly diagnosed patients? And I know that you also led the groundbreaking BCRF supported positive trial. Can you tell us about those two things?
Sure. Well, it is such a difficult thing for a young person to be diagnosed with breast cancer, as we're hearing right now, and it's on the rise. Unfortunately, in this country and throughout the world, the younger patients are more likely to get breast cancer than they were even 10 years ago, even though we talked about it's rare, but it's growing, unfortunately. And so we need to be able to answer these questions. And one of the biggest concerns, beyond the fear of, the existential threat of a cancer for one's future and in the here and now, all the quality of life, all the how you manage your children and get through your busy lives. But it's also about growing your family for women who haven't started a family or women who haven't completed a family. And so that's where personally I've kind of devoted much of my career to say, how can we help women not only live through their breast cancer, but have everything they want, thrive beyond their breast cancer? And that's where fertility preservation comes in. What can we do to preserve fertility? And there are a number of things that women can do. And then how can we help them with the timing of getting pregnant, recognizing that unfortunately, whether one develops ER positive, where they have to take endocrine therapy for long periods of time, the hormone therapy like tamoxifen or an aromatase inhibitor or ovarian suppression, and even in the setting of triple negative breast cancer, people get all these treatments that might impair their fertility. And we tell people typically you got to wait a while, right? Because we want to make sure that the cancer doesn't come back quickly. And we want to let your ovaries repair, assuming you maintain fertility. And if you didn't, we should make sure that you were able to preserve eggs or embryos or take a shot through treatment to suppress your ovaries, put them to sleep, so to speak, so that we can try to preserve your fertility through treatment. So those are the three main things we do. We ask, we support women to be able to bank eggs or embryos, depending on whether they want to have the eggs fertilized, then it's an embryo, right? But that's a big deal. Women have to actually go through a procedure to stimulate their eggs, generally to get the eggs, and then put them in, in vitro fertilization to fertilize them if they so choose. Many women actually do both if they go through the procedure. It's complicated. It's a lot on one's body, and it's expensive, and not everybody's covered. So there's so many hurdles for our young patients to preserve their fertility. Many do it, and increasingly we're learning that it appears to be safe, which leads me to the positive trial, which recently looked at that in the population. But positive was a study where we said, okay, women with hormone sensitive breast cancer want to have babies, and they don't want to wait 5 to 10 years to get through all that hormonal therapy, the endocrine therapy that we recommend to reduce risk of recurrence. And so can we, and we know that most women aren't going to hear from their breast cancer again, knock on wood, I'm a little superstitious, but the survival rates and the recurrence rates fortunately are pretty good and they're improving. Not good enough, and we still need to do research, right? Because any woman hearing from breast cancer again is too many. But how can we help the majority of women who are never going to hear from their breast cancer again to not lose this all important thing, their future fertility, which it is for many women, and be able to have that baby before they should be a grandmother, in terms of, they're watching their friends all get pregnant and looking around going, what about me? Or watching their, toddler get older and saying, I don't want my kids 10 years apart or 15 years apart, and plus their fertility windows closing. So Positive was designed to support women to say, okay, take a good chunk of endocrine therapy, somewhere between 18 to 30 months, come off, have a washout period for 3 months, try to get pregnant either on your own with your partner or a sperm donor, or using your reproductive technology products, banked eggs or embryos, and then carry a pregnancy, deliver, nurse if that's desired and feasible, and then get back on. And the goal was to take off only up to about 2 years. Women get back on, and then we're following them over time because we know that the recurrence trajectory is decades. And as long as they take the same amount of endocrine therapy as they would have, the hope is that there wouldn't have been a big difference in terms of their risk of recurrence. And so we actually ran that trial. We accrued, got women on. Research is the reason. And we got women saying, I can get pregnant on my own, but I want to contribute my information to this important work. We had over 500 women worldwide join this study, and we accrued earlier than we thought we would. That's how important this was to the women interested in, being part of this study. And we presented our first data last year that suggested, at least in early follow-up, 2 things. One is that it looked safe enough. No clear detriment in terms of their likelihood of hearing from breast cancer again. And then 2, the vast majority of women who tried to have a pregnancy actually got pregnant and had a healthy baby. And so it was really great news for our young survivors and for future young survivors. And we're still analyzing this. And just this past December, we presented on is it safe to use the banked eggs or embryos? Is it safe to stimulate for those women that either ran out of banked eggs or embryos, never had the chance to do it, but now they're trying to get pregnant in the middle of this break? And the answer, so far, small numbers, so you have to have caveats around all research, is that it looks safe. And that it didn't look like there was any clear detriment or harm to the women who were able to get pregnant and or the women who had used their products of reproductive technology. So fantastic news. Again, I'm conservative around these things. We're talking about breast cancer recurrence. So you want to make sure that you are dotting I's and crossing T's. And we've only followed these women for, on average, 4 years from enrollment, which is only on average, about 5 or 6 years from their diagnosis. So we have to follow longer to really understand the risks, but it looks good so far. So it was really great news for the community of both patients and the doctors who care for them and the researchers.
Mm-hmm. Well, I mean, it's welcome news, I think, for any patient diagnosed under 40 and or under 50. But it's to me, especially, I think a challenge is that feeling that your choice was taken away, because I don't know how, another thing you were talking about is when you find out that you have a cancer diagnosis, it feels like an immediate emergency and that you need to be in treatment right away. So to ask a patient, this is how much it matters, this is how much fertility matters to young women, they're willing to delay treatment to undergo fertility preservation. That's how much it means to them, because it is a huge decision, one that I couldn't make, actually. I didn't undergo fertility preservation, even though my doctor reassured me a million times and said, it's fine, please do it. But it felt like my house was on fire and I had to put it out. I'm not going to wait to put my house on fire. I'm not going to wait to put it out. So all to say, it's exactly, these are emotional things, and it's again a really weighty subject, and I'm sure welcome news to a lot of women. Now, I do want to get into a little bit about how do we address this younger rising incidence in younger women. Of course, at BCRF, we're looking at this through a multi-pronged lens, because it's a multi-pronged problem, right? And one of the things that we need to get better at right away is risk assessment and understanding how better to identify patients below 40 that are not getting screened that should actually be getting screened. Like, who are those people? Because mass screening, age-based screening is not the solution, right? It's going to be being better at identifying those high-risk patients, which is why, of course, we launched the Precision Prevention Initiative, and using technology, using AI and all kinds of models to try to better, more precisely figure out who needs to get screened and monitored and maybe take preventative measures. Now, can you talk to us? I mean, of course, Olivia Munn made the term breast cancer risk assessment a really hot topic, and everyone was doing it online. Can you share what that is? What is that breast cancer risk assessment, and who should get it?
Yeah, so I think, there are a number of breast cancer risk assessment tools out there. And I think the most important thing is using it. Women being aware as a young person that they can get breast cancer, talking to their doctors, looking online, using one of these risk assessment tools, and trying to understand their own personal and family potential for predisposition. That's the low-hanging fruit. If you have a father whose mother had a young breast cancer, or sister had a young breast cancer, or, everybody thinks about their mother. They don't think about their father, but these things come on both ends. So if you can use one of these tools, that will be teased out to say, whether you have a strong family history right there. And then that's someone who should probably speak to their doctor around getting genetic testing and doing, at least at a minimum, BRCA1 and BRCA2. And now we do more expanded panel testing to understand risk. And again, I remind people, it's not just about the risk on your mom's side. Half your genes come from your father, so don't disregard your father's side. And it's not just about breast cancer. Sometimes, it can be a sneaky prostate cancer that comes in a man at a young age that says, or pancreas and prostate, and that can be, spoiler alert, can be BRCA2, especially at young ages, or lots of patterns. So trying to think about that's critical. And then using one of these tools, we've actually developed one at Dana-Farber as well called Assess Your Risk, that is available online. And you can use, again, there are a number of tools to use. So I wouldn't necessarily say you must use one or another, but trying to understand your own risk and then talking to your doctors about consideration of testing. And if your own doctors say you don't need that, go to a center that has a cancer risk and genetics group. All of the big cities have centers like this. They have websites that can teach you more. They have filters that can help to get you in and get you into the right place. And certainly, obviously, if you have symptoms of, lumps or bumps or dimpling or rashes on your breasts, go to your regular doctor. And if you're told it's nothing, get a second opinion if you're worried about it.
Mm-hmm. And I will add that we are supporting one of a BCRF funded researcher, Dr. Laura Esserman, is leading the Wisdom trial, I believe. I should take that back. I believe she's leading the Wisdom trial.
Yes.
Currently enrolling 100,000 women ages 30 to 74. If you haven't already been diagnosed and you aren't currently getting screened, or even if you are, you can sign up there and they'll send you all kinds of information on whether or not you should be getting screened based on a lot of factors, including a polygenic risk score.
Which is where we're going to learn so much more. And I'm so glad you brought that up, because participate in that research study, Wisdom it's called, and if you Google it, you'll find it if you can. But the other big thing is, like I talked about, the obvious, clear hereditary predispositions of the big genes, BRCA1, BRCA2, PALB2. But there are these polygenic risk scores that you just alluded to, which are not as clear cut, but I think are going to be the answer. Most of our young women don't have a clear genetic predisposition. And so, it's about somewhere between 15 to 25%, depending on which group you look at. And that means 75% plus are probably more about some nature-nurture combination that these polygenic risk scores and other novel investigations will teach us. So participate in the research so we can learn, so that our daughters can have access to those kinds of calculators to figure out their risk. And then, of course, it's about, and what can you do to either detect early or prevent? Because we know that right now the prevention strategies are pretty tough. and they're important to know about, but not everybody's going to avail themselves of it. So it would be fabulous if we could come up with better modalities for that.
Right. And, we have just a couple of minutes left. So I'm going to speed through a couple of things. And I wanted to ask one question that came through. So of course, one of the other things I mentioned was improving risk assessment, but we also need to improve the screening modalities available for women with dense breasts, because as we know, young women are most likely to have dense breasts. And we talked a little bit earlier about how doctors and a lot of patients experience hesitance even when they present with breast cancer symptoms. And so improving those screening technologies and making the medical community, the healthcare community, feel confident in the results that young patients would get, I think will help us move that forward. And so we have researchers that are working on things like using AI models to better predict breast cancer in younger patients, as well as using contrast enhanced mammography for women with dense breasts, which would, initial trials show that they improve results and accuracy by about 80%. So we're looking into all of this, but it is this sort of multi-pronged step that needs to happen to, not just improve figuring out who needs screening, but then making that screening more accurate, right, for younger patients. So those are just a couple of things, but I did want to touch, I saw a question come through that I thought is probably interesting to a few people. I think we wanted to talk about, I'm going to make this a little bit more general, but during chemo, diet and exercise during chemo and what that's like. So of course, we have researchers that are working on that now. And, Dr. Partridge, if you have any insight on that, I'd love to hear as well.
Right. So that's an area of active investigation. Number of BCRF investigators, including at my own institution, are looking at this. And generally, we do recommend that people exercise through treatment as best they can so they can stay fit. We think that just common sense wise, that's better for people. And you're actually, with breast cancer, you're more likely to gain weight than lose weight with adjuvant chemotherapy in particular. And people tend to be less active, which is, again, you don't want to victim blame or anything, just kind of do your best to keep moving through this as best you can. What there is right now is a kind of not ready for prime time, but really interesting data surrounding fasting and whether or not that might improve how people do through treatment. Totally not ready for prime time. In fact, we just discussed this in our breast group and said, we are not telling people to fast. We'll have a bunch of people passing out in the clinics when they come for their chemo. But what we do recommend, and we're studying this stuff to see whether or not it may, whether it's all, smoke and mirrors or it really is scientifically valid. Right now, what we recommend is that people eat a prudent diet through treatment and beyond. What's a prudent diet? High in whole grains, fruits and vegetables, good fats, not bad fats, not, saturated fats, and not a ton of red meat. And so, it's kind of that Middle Eastern diet, not the American diet. Try not to eat, or make it the nouveau American diet of lots of good, healthy fruits, vegetables, and whole grains and lean meats.
Right. Right. I just listened to Dr. Neil Iyengar talking about this 2 days ago, and how exercise moderate intensity, about 150 minutes per week, and a plant-based diet, or at least plant-forward diet, seems to improve response to chemo as far as we can tell now. I wanted to touch really quickly on two things. A question came through. The group that I mentioned earlier was called Motherhood Through Cancer, and that's Marcella's Substack. Please subscribe.
It's growing.
Yes, it's growing. And there's a great question here that Dr. Partridge, you mentioned an increased risk for breast cancer with pregnancies post 30. Does that mean risk of recurrence is higher for pregnancies post 30 as well?
So the short answer is that no, there is a slight blip in some people postpartum in terms of their risk of recurrence, but we haven't teased out that actual effect yet. So the short answer is, at this point, I would say that it really is about increasing the risk overall for getting a breast cancer. The recurrence data we don't have yet on a population basis, but when we've looked in some small studies, there are certain types of breast cancer that may be higher risk of recurrence when they happen in a postpartum state, meaning that 1 to 5 years or so after a pregnancy, compared to other breast cancer diagnoses. So you have to be very careful about your comparisons. And again, that one I would say is still kind of in the research zone. I don't treat my patients any differently, nor should anybody else, whether they're diagnosed in the postpartum phase of their, kind of fertility, or they're diagnosed before they have babies, except paying attention to their fertility. But otherwise, we should not be treating them any differently or treating them more aggressively or less aggressively based on the postpartum status or not. That could change, but right now we don't have enough data or science to tell us to do anything differently. But it's a really good question.
Mm-hmm. And there's one question specifically on your thoughts around liquid biopsy and how ready, whether that'll be useful and how ready it is for prime time.
Yeah, so we are looking at liquid biopsies, which means looking in the blood and the plasma for pieces of the tumor, either DNA or tumor cells that might still exist. And there's been some early data that has suggested in patients with disease that has spread, metastatic disease, that the amount of, and amount is a kind of gross term I'm using, the amount of tumor pieces that ctDNA or circulating tumor cells and what they show in terms of their genetic makeup may be associated with how people do. And then that's also appearing to be true in women who have been treated for early breast cancer, are NED, meaning having no evidence of disease at this time. But if there is ctDNA or tumor cell evidence in the bloodstream, that has been associated with a higher risk of recurrence, even in the absence of overt recurrence at that time. We're not looking at that routinely in clinical practice yet, but there's a ton of research going on trying to understand kind of what it means, how sensitive a test is it, how specific it is, and then what we can do about it, most importantly. So can we intervene and prevent a recurrence in that setting? And there's a lot of work going on right now trying to both understand the risks and then get in the way of the risks.
Mm-hmm. Yes, I find liquid biopsies to be such a bright light for the future as well, because I think I had a double mastectomy, and so there's no screening for me anymore. I'm not going in for mammograms. And so for me, liquid biopsies is really the only screening technology I have to look forward to in the future. So I'm really particularly hopeful for that. Is there, of course, we're going over time. I promised you guys I wasn't going to do that, and of course I did. Is there any last thing that you'd like to share? Is there anything we haven't said already that you'd love to share? Marcella, I'll start with you.
I think it's so, going back to this question of like motherhood through cancer, I think one of the most healing things that I did is I reached out to people on the other side of treatment. And what I would say is that I am somebody that would love to connect with anybody who is, going through treatment that needs support, even if it's just for, just to say, look, we get through it. There's a lot of us. We are a sisterhood. And I really do mean that. I mean, Sadia, you're I feel like you are a sister to me at this point. And it is one of the bright sides. I mean, I hate to, I'm not trying to suggest that there's even bright sides, but there is just a beautiful community and you don't have to go through it alone. There's so many of us that want to help you through it. And so I think just really, emphasizing that is all I wish to, depart on.
Yeah, and I would just add, it's hard to add anything to Marcella. So I would say that I think the most important message is, get the help you need from your friends, family. Don't be afraid to ask specific tasks. And then also, don't be afraid to question your doctors and providers. As a provider, people always say, oh, I'm sorry to be asking you that, or that people get a second opinion. They don't want me to know. And I'm always like, I want you to get a second opinion if that's something that'll make you feel comfortable. My job is to take care of you and make you as comfortable as possible in a very uncomfortable situation. So if that's going to help you, and I always say to people, look, I'm happy to learn. If they come up with a better idea, I want to hear about it. And if I disagree with it, I'll tell you why. And if I can't tell you that, then you should find another doctor. And I should be able to handle all those good questions that people have from both the patient and their family and their friends. So feel empowered in that. Make your lists. go in and make sure you have a good relationship like that, because it's kind of a really, as we talked about, you're going to be seeing your doctor and the whole team for a pretty long time. So you want to make sure that you have trust and confidence that you're getting what you need.
Yeah. Thank you. Well, thank you both for taking the time to speak on this topic. Like I said, I know it's an emotional one. It's really hard, and I just really appreciate your expert insight, and thank you for joining us.
Thank you for having us.